Many wellness arrangements condition earning an economic reward, like a $200 cash payment, on completing an activity like a health risk questionnaire, biometric exams, or spending time with a health coach. These kinds of incentive structures of do this and earn that rarely result in optimal participation levels. To reach optimal participation levels, we need to integrate the wellness incentives and the choice architecture within the medical plan. Let me share with you an example of a case study. In this case study, we have a healthcare organization with approximately 15,000 employees, which had offered two different medical plan options historically, an HMO option and a PPO option. They also had wellness incentives that were amounted to $338 for completing a health questionnaire and biometrics. This organization really struggled to get participation above 55%. So what did they do? They reconfigured the wellness incentives into the choice architecture of the medical plan. So they introduced a healthy HMO plan, a healthy saver plan, which is kind of like a consumer-directed health plan, and then a basic plan. The only way that you could participate in the healthy HMO plan or the healthy saver plan was to complete the health questionnaire and the biometrics. If you didn't complete those, you were placed into a basic plan, which had lower coverage and higher payroll deductions. With this new choice architecture, this particular healthcare institution increased participation in their wellness program from 55% to 98%. A startling result, but one that's not surprising when behavioral economics are leveraged. Another example of effective choice architecture is with a client of ours that's a nuclear power plant. Their workers had 5 different medical plan options, named options 1, option 2, 3, 4, and 5. Option 1 was very expensive. Very rich plan, but very expensive. In fact, it made no sense for anybody to choose option 1, yet 31% of the workers in this nuclear power plant did choose option 1. What we did was we reconfigured the choice architecture by reordering the plans, renaming the plans, without changing any of the underlying economics in the plans. And the result? That 31% of workers that made suboptimal decisions decreased to 20%. That was a good result. People make a lot of suboptimal decisions about their health. These kinds of decisions can lead to disease. Choice architecture can be really helpful in helping people make better choices. I'd like to share with you a few of my favorite tangible examples of effective choice architecture in nudging people toward better health. Let's start with diet. What is healthy to eat and what is not? An economic solution would be to increase menu prices for items that are less healthy and subsidize items that are healthier. A supply control solution would be to stock vending machines with healthy options and perhaps outlaw the use of trans fats and the sale of high-volume soda drinks. Behavioral solutions are a little different. One premise: let's make it easy, not difficult. For instance, we could label all of our food items with calorie and carbohydrate and sodium numbers. Or we could do something simple, like what the Cleveland Clinic does. They place green Go stickers on the healthy food items in cafeterias and local stores. Very simple solution. Another idea: make some things difficult, not easy. For instance, make unhealthy food items in the cafeteria hard to reach. Put them on the bottom shelf. Allow for the use of credit and debit cards to buy healthy foods, but you've got to pay cash for desserts. You're making things difficult, not easy in some cases. One of my favorite examples is the creative use of defaults. There's a large employer that sells pizza in its cafeteria, and if you don't specify that you want flour crust, you get whole wheat crust in your pizza. That's the default.